An estimated 10 million people suffer from critical limb ischemia in the United States, and we have seen a marked rise in endovascular revascularization for treating these patients. However, the rise of endovascular procedures in general has raised some concerns, as a new paper in JACC notes nationwide trends of hospital admission and outcomes among adults with critical limb ischemia from 2003 to 2011. And to talk about this, I'm with Dr. Mehdi Shishehbor, who is a DO, MPH, and PhD, and the Director of Endovascular Services in the Department of Cardiovascular Medicine at the Cleveland Clinic main campus. Let's start with the concerns you mentioned in the very opening of your paper in JACC regarding these endovascular procedures. There has been some concern.
Well, there's been an uptake of these procedures because in general folks feel that these procedures are low risk, they are minimally invasive. Obviously, the patients always like it when you're offering them something that is less invasive relative to surgery. So there's been a rise. There's been a couple articles in the public domain related to that. And I think that the field has been concerned that maybe the public is getting the wrong impression as to why this rise has been and what the impact of this rise has been on the care of patients with PAD.
So is that why you did the study, to try and answer some of this?
Yes, honestly, this was when this public reporting came out in the public domain, the news about the rise in the endovascular, and there's also been concerns in the field of CLI. As you know, critical limb ischemia, this is the most advanced form of PAD. These are folks with rest pain, ulcers, and gangrene. Right. And there's been data for the past 2 to 3 years showing that a lot of these patients, actually between 40 to 70%, undergo amputation without any revascularization. So we have these two dichotomous piece of information. We have some folks that they say there are too many procedures happening, and yet there are these publications showing that actually the patients that deserve this revascularization, deserve these procedures, are not actually getting them, and they're undergoing amputation. So we wanted to kind of put our head together and try to see, okay, what's the contemporary data looks like? What are the trends? And we wanted to do it in a large population of patients to try to understand what does this rise mean? How does this relate to open surgery, which has been going on for decades? And how does that impact the outcomes of the patients?
So what was the source of the data?
So the source of the data was from the nationwide inpatient sample. This was over 650,000 patients with critical limb ischemia. One of the things that honestly separates this manuscript from other manuscripts that have looked at similar PAD population is that we really wanted to focus on the most advanced form of the disease, which is critical limb ischemia. So we did not include patients with claudication or Rutherford class 2 or 3. These were all folks with Rutherford 4, 5, and 6. Because these are the folks that are at risk of amputation. These are the patients that are having pain. They have significant psychosocial stress, and they really suffer from this condition.
So you really have a large patient population from which to draw some conclusions.
Absolutely.
What were your conclusions? What did you find?
Well, we found many things. We have a lot of data in the manuscript, but some of the highlights were, I think one of the things we really need to highlight is the fact that the patients are getting sicker. So if you look at the table 1 of the manuscript, we see that the prevalence of obesity, diabetes, hypertension, hyperlipidemia, chronic kidney disease, and prior revascularization is going up through the last decade. So the patients are getting sicker. So obviously we need to pay attention to that. We need to try everything we can to try to prevent folks from getting diabetes and to try to treat them more aggressively, and obesity and all the comorbidities that lead to critical limb ischemia. So one is that we need to prevent those. Second is that when we get these patients now compared to 10 years ago, these patients are much more comorbid because of higher prevalence of these conditions. So that was one finding. The second finding was that we showed that in the last decade, the rate of admission for CLI has remained constant, while more importantly, the rates of amputations have declined, the rates of mortality have declined, and the rate of surgery has declined. While in the meantime, the rate of endo is going up. So obviously we can make some inferences. We can never say this is a causal relationship, True. As you know. But this is now the 3rd, 4th publication showing these trends. But I think what's interesting is that we see that the rise of the endo correlate with these decrease in amputation and mortality, which if it was explained by medical therapy, you would think that that would have led to lower admission rates over time, because in my mind, medical therapy impacts, admission less than it impacts amputation. We don't have any data that medical therapy actually impacts amputation. So given these findings, we think that, the rise in the endovascular has had some impact on the amputation. And then lastly, we compared endovascular to the surgical approach. So we wanted to know from the two approaches that are available, from the standpoint of revascularizing this patient, which is the more superior one. And we showed that endovascular approach compared to surgical bypass was associated with lower mortality, was associated with a lower length of hospital stay, and was more cost effective. So overall, it appeared that endovascular approach was superior than open surgical approach in these 650,000 patients.
Now, because you had such a large patient population, you did some sub-analysis. There were some gender-based disparities in treatment and outcomes evident in this analysis,
Yes.
correct?
Yes, so we not only gender, but there were many things actually, some interesting findings. For example, others have shown this, but we showed, for example, that there was significant disparities by geography. There was significant disparities related to socioeconomic status. There were significant disparities related to race. So, for example, African Americans were much more likely to undergo amputation and much less likely to get revascularization. So they were getting less revascularization, but they were yet getting more amputation. Same thing with socioeconomic status. So we did show a number of subgroup analyses where we identified a series of disparities that are persistent in the field of critical limb ischemia and PAD.
And one of the things you remind readers of the paper is it must be emphasized that patients with chronic limb ischemia harbor an elevated atherosclerotic burden in multiple vascular beds, predisposing them to increased vascular morbidity and mortality, period.
I mean, if you compare critical limb ischemia to any type of cancer, congestive heart failure, these patients do much worse than patients with congestive heart failure or even cancer. They do even worse in patients with end-stage renal disease on dialysis. The unfortunate thing is that many times patients with critical limb ischemia are those that also have end-stage renal disease. They are also the patients that have congestive heart failure and have diabetes. So now you combine those morbid conditions with critical limb ischemia, and then you have a patient that is at risk of death and amputation and other severe consequences of this condition. So yes, these patients are very sick. We have to treat them as a holistically. We need to deal with the risk factors, as you mentioned, treat the whole patient, but we also need to focus on the limb. We need to offer them revascularization as fast as we can. Time is limb, like we used to say time is muscle for the heart. Now we say time is limb, so we need to immediately revascularize this patient. We need to offer them the best approach. In most cases, it appears to be endovascular approach, and we need to take a holistic approach, as you noted.
So this should be encouraging, and it should maybe get rid of some of the debate so that people are a little bit more welcoming of the idea of maybe revascularization is an option here.
Yeah. I think definitely supports the idea that I think I'm comfortable even saying that without a shadow of doubt, if a patient is a reasonable patient from a standpoint of comorbidities, obviously there are some patients that benefit from amputation because they're in nursing home, they don't walk. We're not talking about those patients. But if the patient is someone that can walk and ambulate and is a reasonable patient, revascularization should be offered. The second question is that should they be offered endovascular or surgery? I think it should be personalized, but at least based on the data that we show here and other publications such as the Basel trial, it appears that endo is a very reasonable option, is less invasive. So if the patient has good anatomy and they're experienced operators, then endovascular approach may be the first approach. And then follow to that is that we have some work to do. Obviously, we need to deal with the prevalence of diabetes, obesity, hypertension, and all the comorbidities. Hopefully we can impact these patients before they get CLI, and we can stop the disease before it gets to the end stages.
Well, if you need a little more confidence in the procedure, please check out the April 26 issue of JACC for the main paper and the editorial comment. And for CardioSource World News, I'm Executive Editor Rick McGuire.